Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, A Randomized Controlled Trial of a Structured Intervention to Facilitate End-of-Life Decision-Making in Patients with Advanced Cancer by Rhea Stein et al. My name is Mary Buss, and I am an assistant professor of medicine at Harvard University. I practice both palliative care and gynecologic medical oncology at Beth Israel Deaconess Medical Center in Boston, Massachusetts. Despite substantial improvements in cancer treatment and survival, approximately 1 out of every 3 patients diagnosed with cancer will die of their disease. When asked, most patients with cancer express a desire to know their prognosis. Knowledge of poor prognosis affects patients' medical decisions. For example, it has been shown that patients who know they have less than 6 months to live are less likely to pursue chemotherapy. Likewise, patients facing a terminal diagnosis often express a desire to maintain comfort, control, dignity, and to avoid a prolonged dying process. Many patients, when facing incurable cancer, will prioritize comfort and elect to forego aggressive medical interventions that have low rates of success. A primary example of this are Do Not Resuscitate, or DNR orders, which document the choice to forego attempts at cardiopulmonary resuscitation, commonly known as CPR. Many ill patients also prefer to die at home rather than in a hospital. In the article that accompanies this podcast, Stein and colleagues conduct a randomized controlled trial aimed at improving rates and timing of DNR orders. 120 patients with metastatic cancer being managed with non-curative intent were randomized to either usual care or an intervention consisting of an informational pamphlet and a discussion. The authors hypothesized that their intervention would result in more and earlier DNR orders, as well as fewer hospital deaths. Secondary outcomes included measures of CPR knowledge and measures of psychological harm. The study was conducted at 2 hospitals in Sydney, Australia, between 2004 and 2006. The authors conclude that their intervention did not alter the proportion of DNR orders, but note that the prevalence of DNR orders was high in both groups, between 68 and 76%. Patients who received the intervention had DNR orders placed earlier, 27 versus 12.5 days prior to death. This difference narrowly missed statistical significance on the intention to treat analysis. Of patients who received the intervention, 19% died in the hospital, compared to 50% on the control arm, a statistically significant difference. Again, using their pre-specified intent to treat analysis, 30% of the intervention arm died in the hospital. This narrowly missed statistical significance with a p-value of 0.056. Improvements in understanding the outcomes of CPR were modest in the intervention group. There was no indication of psychological harm of the intervention based on the hospital anxiety and depression scale. Stein and colleagues, as have many investigators before them, chose DNR orders as a marker for end-of-life decision-making. Is this focus on DNR appropriate? Many medical providers spend considerable time and emotional energy on obtaining DNR orders for patients with advanced illness. However, we need to recognize that DNR orders are merely the tip of the iceberg when thinking about advanced care planning. These authors fail to show an increase in the proportion of DNR orders in the intervention arm. At first, this may suggest that the approach was ineffective, but in reality, this observation demonstrates a simple fact. It's hard to die without a DNR order. Numerous studies, such as the landmark support trial, which raised awareness of the poor quality of end-of-life care in U.S. hospitals, document the late placement of DNR orders. just 2 days before death on average. But even in these studies, very few patients with cancer received CPR prior to dying. Thus, the timing of the DNR order seems a better marker for the quality of end-of-life decision-making. In this study, the intervention occurred on average 310 days prior to death, but DNR orders were not placed until 27 days prior to death. Notably, the conversation itself was not focused on obtaining a DNR order. As the authors described, the psychologist who led the discussion asked such questions as, have you been able to talk to people in your life and settle unfinished business? A thoughtful conversation earlier in the course of illness may effectively facilitate decisions later in the course of illness and may lead to a change in other meaningful outcomes, such as place of death. Of course, the conversation needs to occur to be effective, as only those who receive the intervention derive benefit. This intervention in this study was a distribution of a pamphlet and an advanced care planning conversation by a highly skilled psychologist, raising two important questions. Who should conduct these discussions, and what is the role of the oncologist in these discussions? Physicians repeatedly cite time as a barrier to addressing advanced care planning with patients, so the use of an allied health professional to conduct such conversations may be an appropriate division of labor in a busy oncology practice. While psychologists may be uncommon, social workers, nurse case managers, and palliative care specialists are frequently members of an interdisciplinary cancer care team. Such individuals can be tasked to lead these conversations, but with one important caveat. The subjects in this study were all aware of their prognosis. The authors did not describe how prognostic awareness was determined, but its presence creates an important selection bias. Several studies by Temmel, Weeks, and others demonstrate that many patients with advanced cancer harbor an unrealistic impression of their prognosis, despite their expressed desire for prognostic information. The responsibility to communicate prognosis and the palliative intent of treatment remains incumbent upon the oncologist. Once patients understand prognosis, the present study suggests that an allied health professional, who may have more time than the physician, can continue the conversation with clinically meaningful results. Finally, this study confirms findings from other studies that discussing end-of-life issues with patients does not lead to emotional or psychological harm. There is even a suggestion of benefit to patients based on their expressions of gratitude, a finding that corroborates my own clinical experience. Such findings do need to be interpreted cautiously. Ironically, a recent study by Weeks and colleagues reported in the New England Journal of Medicine in 2012 showed that patients with better prognostic awareness gave less favorable ratings of their physician's communication. Also, certain populations of oncology patients, such as those seeking to enroll in Phase 1 clinical trials, may not be receptive to advanced care planning discussions. In summary, Stein and colleagues have shown that a relatively simple and efficient intervention, a single conversation by a mental health professional, and a pamphlet offered early in the course of advanced cancer may effectively facilitate end-of-life decision-making later in the illness trajectory. This study supplies some evidence of the benefit to advanced care planning earlier in the course of illness for patients with incurable cancer. This concludes this JCO podcast. I thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.